Good afternoon, everyone. Am I audible?
Yes, sir, we can hear you.
Yes, sir, you are audible.
Okay, sir. Thank you so much. Good afternoon, sir.
We
How
can
is it?
hear you loud and clear. Pranam. We can hear you loud and clear.
Thank you. Thank you so much, sir. Last time that mic was not working, na, that's why I was concerned.
नहीं नहीं अब कुछ नहीं होगा यार बंद कर मोबाइल इनका
A very good afternoon to the distinguished panelists, speakers, faculty from the Nursing College and RDF students. On behalf of the Institute of Liver and Biliary Sciences and the MP campaign, allow me to extend my very warm welcome to the College of Nursing, the host for the day, to the national webinar on recent advances in prevention and control of hepatitis B and C. As a healthcare professionals, especially as a nursing staff, you do play a critical role in utilizing your chronic disease management skills to support the testing, diagnosis, and management of people with chronic hepatitis B and C. With a broad-based training in nursing, you become a professional having essential overlaps in healthcare, and most importantly, a nursing professional largely works with the patient where they find opportunity to interact, connect, and even counsel the patients. There is an immense confidence that a nursing professional may command of the patient, and therefore nurses can facilitate and support lifestyle modification strategies required to improve patient outcomes. It is these modifications and behavioral changes which definitely play an important role in management of chronic hepatitis and may even help in prevention of transmission of viral hepatitis by educating about safe practices, needle stick injuries, and safe sex, etc. We'd be flowing through the webinar just to give you an outlay. We'd be beginning with the National Viral Hepatitis Control Program, discussing the burden of HBV and HCV in India, the transmission and prevention of HBV and HCV at community level, and then we would also attempt to learn about the screening, vaccination strategy, and health education for HBV and HCV at community level. The program will then flow into a beautiful ceremony, the I Pledge Oath ceremony, which would request you all to kindly take the pledge and show solidarity with the cause. The nurses' involvement in hepatitis B prevention, testing, management, and treatment is guided by the individual nurse's scope of practice and the context of the setting in which care is provided, where you may find the scope of improving the health services outreach in terms of viral hepatitis. We'd have one of our distinguished speakers also talking about the vaccination, in which the nurses do play a role in consult. You may discuss the need for hepatitis B testing prior to the vaccination for priority populations. Your work also might lead you to educating the patients, where you might be required to provide education and encourage testing of priority populations. So I do hope that this webinar certainly will be of great help in equipping you with the knowledge on these aspects, getting informed about how the nurses working in the general practice setting can incorporate hepatitis B care into their existing role. Our speakers today are distinguished faculties from the eminent medical institutions and are prolific in keeping the sessions engaging and quite interactive, as you'll all see. So once again, a very warm welcome on behalf of ILBS and the Empathy Campaign. Allow me to now welcome our much respected and cherished Dr. Umesh Kapil for a keynote address and begin the sessions. Sir, please.
Well, good afternoon to all of you. First of all, my most sincere thanks to Principal Ma'am, Mini George Ma'am. We are most grateful to you for organizing this webinar, national webinar on recent advances in prevention of hepatitis B and C. And I know it that most of you or majority of you would be very knowledgeable in this area because this hospital is essentially based on hepatobiliary diseases and all diseases pertaining to liver. So I know it well. I remember that when I joined in 2019, ILBS, I had a privilege of listening to a lecture by presentation in the ECO project by one of the nursing faculty, and she was talking about the needle injury for with a hepatitis B patient. I think that was a very important topic, and I learned a lot because when I was working in AIMS in the Department of Gastroenterology and Food and Nutrition, I was not aware about all these practical applications and interventions which are required. So, and then we have another faculty, she talked about the, I remember her name as Mrs. Madhvi. She made a very good presentation in the ECO project, and it was a very great learning for me. And obviously we have the principal, ma'am, Dr. Mini George. She is the guiding force about these developments. And I'm personally thankful to all the faculty members and all the students who have very kindly agreed to participate in this webinar. I can assure you that end of the day, you would find that you have learned something extra than what you know about viral hepatitis. I'll briefly touch upon different aspects of viral hepatitis. Just remember that, and all of you must be aware that there are 5 types of viral hepatitis, and the most common mode of transmission is essentially we have what happened?
You can scroll through the slides.
We have contaminated food and water which are being consumed by the population. And second is bloodborne transmission. And this bloodborne is also all the products of the blood are responsible for it. Now, this is a very common photo or a picture which is being talked about. We have hepatitis A, B, C, D, and E. And we have a large percentage of our population. They suffer from hepatitis disease per se. And unfortunately, this hepatitis has not been given its due importance. And basically, like say, for example, it causes more deaths combined to malaria, tuberculosis, and HIV. But still, hepatitis has never been on the agenda of the government of India to give it a high priority. Yesterday, we had a webinar in which one of the students or one of the participants asked us why poliomyelitis is given so much importance and why hepatitis not being given importance. Now, what happens is sometimes some of the programs of the government of India run in a mission mode, and poliomyelitis is same. Now, recently, measles is being accorded, tuberculosis is being accorded, but unfortunately, viral hepatitis has not been accorded, and we are trying our best to provide different impetus to the program. Now, this is another slide which talks about the A, B, C, and D is usually in patients who is a co-infection or superinfection in patient with hepatitis B. Now, we do have in our country many interventions. Like we have vaccination of hepatitis B. We do have vaccination for hepatitis A, but it is a very costly and somehow it has not been included in the system. But yes, in the private system, this is being included. Now, food and drinking water, definitely yes, it causes the hepatitis A and E. So we talk about basically the safety of the blood and its products. That's very important. And we do have if you look at last 20 years, we have made a tremendous progress in safety of the injection which are being used. The disposable needles and syringes are maybe last 30 years. And thanks to the HIV disease per se, now HBV is being all blood transfusions, all blood products are which are being given by the blood bank. So all the blood is being screened for hepatitis B and HIV infection per se. Now, we do have many programs which are working in our country, implemented by the government of India. But we must remember that still it's an important cause of mortality amongst the low socioeconomic group. And if you look at the viral hepatitis A, it is a very common, still people think it is a common disease because it comes and passes through. But what has been known that one in about 100,000 subjects or patients, it leads to acute liver failure. And the survivors of the acute liver failure are very few. Now, this is a very nice, although it's a very dark one, just remember that all the tube wells, which are hand pumps, which are being used near the juggies, they come from a shallow water level. And the one which is deep tube well, there's a rocky layer, this deep tube well goes below this. So what happens is all the water which gets absorbed into the soil goes into the superficial layer, and this low level of water which is being collected, it comes back. And this is a very important cause of all the waterborne diseases, including the viral hepatitis A and E. Now, I'll just try to put down a few things in a very simple perspective that particularly for today's topic, hepatitis C is a very common disease. And what is happening is it spreads through the blood and its products. And that's the risk of, although the sexual transmission risk is much lower due to in the hepatitis C as compared to HBV. But still, we do have quite a common problem of hepatitis C, particularly amongst the people who are intravenous drug users. Okay. Now, the fortunate part is that what we have is that although uh, we don't have a vaccine against hepatitis C, but we do have a treatment. And this treatment costs, I must admit to you, that is one of the cheapest or most economical costs we have in our country. If we have about, I think so, it's about $200 or $300 in India. But if you go to the neighboring country, Bangladesh, it is $20,000. Why? Because the government of India has taken a position that all the drugs which are used for HCV treatment would be tax-free. Okay, or a very minimal tax is being put in. So a lot of people from neighboring countries come to our country for the treatment of hepatitis C. And some of the states like Punjab, where the IV drug users are much, much higher, injection drug users are much, much higher, they have made it compulsory and totally free for the treatment of HCV. Now, what is important is we must remember that hepatitis C, about 15% of the cases naturally resolve and 85% requires treatment. Now, this is something important, but we have the medicines available, and particularly for the poor people, we do have free medicines available in our country. As I mentioned, there's no vaccine, but there is a cure for hepatitis B. Now, what my personal experiences is that the nursing officers play a most important role. Doctor come and they visit and then just give advice and go. But nursing officers are the one which interact more with the patients at their own level. Okay, the patient relatives, they ask nursing officer what is to be done, how it should be done, and so on and so forth. So you play a very important role. I think so. It's more than doctors play a small role, but you play about 80 to 90% of role in the counseling of the patients. But one, remember that we do not have any adverse pregnancy outcome when amongst the mothers with hepatitis C infection. Similarly, it has been seen that one of the common source of cause of hepatitis C is vertical transmission, that is from mother to the child, newborn. Now, do the positive mother breastfeed? Yes, they are being recommended that they should breastfeed the child because the risk of having the morbidity due to non-breastfeeding is much, much higher than the risk of any disease or any side effects due to feeding in the positive HCV positive mother. Dr. Ajit, please correct me if I am wrong in your presentation. Now, similarly, when you talk about the infected hepatitis B, again, one of the most common causes from pregnant mothers to the newborn is the most common cause. And what has been seen that in our country, although this is last 20 years, the hepatitis B vaccine is now become so economical that it's affordable and it's being available throughout the country. It's a universal coverage which we have for the hepatitis B vaccination. But just remember that people don't take it. Even if you look at the data of the DPT vaccine coverage is about 80%, 85%, which is also given by mode of injection pen route. But in the same place, same district, you find that the hepatitis B vaccination coverage is about 50%. So there's a gap of about 30%. Why? There are many issues with that, but these issues are essentially the management issues which can be taken care of. Now, who are the major risk factors is essentially who have the sexual partners of an infected person, those who use the injected drugs, healthcare workers, but which is again an important issue that healthcare workers do have a chance of needle injury. So how that should be managed, I think so Dr. Ajit would take care of this particular aspect. Now, what is important is that when the newborn have the infection, 90% they become into chronic infection. And amongst children, it is when they receive the infection, it's only 30%. And when the adult, it's 1 to 5%. Now, this similarly, we have the recovery that how these patients have recovery for the hepatitis B disease per se. Now, this is something very important that during the pregnancy, if a person have hepatitis, if a mother have hepatitis B, it's a common sort of a thing. It just, it's nothing extra which is happening. A normal, small percentage requires the what you call antiviral treatment, but it's like a normal. But what is happening is that we must take care of vaccination of the pregnant mother during her pregnancy. Even now, what is happening is that all mothers are being screened for the hepatitis B vaccination. This is very important. And this is gradually going from the urban area to the rural area also. Although we have difficulties as of now, the kits are, rapid testing kits are not available, but yes, it just depends upon the amount of funds which are available in the government system. Now, as I mentioned to you, one of the most common cause of infection or continued chronic B patients is the vertical transmission, that is pregnant mother passing it to the newborn. We do have treatment guidelines, protocols by which we are able to take care of these transmission can be reduced. However, the facilities to the 78% of the population residing in the rural area is limited. Now, it has been seen that when the two groups were compared, the mothers with infection, HBV infection, and without infection, it has been found that birth defects are not much different. So these are some of the issues which are important. And I'd just like to say that please ask as many questions as much possible so that you are aware about two important aspects I would like to say. One is needle stick injury. Second is impact of hepatitis B and C during pregnancy, right? This is something. And third is, and most important is breastfeeding by the HBV positive and HCV negative mothers. So with this, I would like to thank Dr. Namrata and our colleagues for giving me this opportunity. Thank you very much.
Thank you so much, sir, for very enlightening and in a very simplified way. You did cover all the aspects from vaccination to transmission to even prevention. And especially I like the understanding of the shallow wells. So I believe that was quite enlightening for all the students as well. And an honorable mention to Dr. Shiv Kumar Serene, the Vice Chancellor, ILBS, who's the Senior Professor, Hepatology and Director, Institute of Liver and Biliary Sciences, New Delhi. He was instrumental in setting up the Institute of Liver and Biliary Sciences and under the auspices of Government of Delhi. He also is the director of the WHO Collaborative Center on Chronic Liver Diseases and Viral Hepatitis at ILBS. He continues to serve as the adjunct faculty, molecular medicine at JNU due to his deep interest in contributions to translational sciences. It is because of him that we are and is empathy. Welcoming on next, the speaker for the next session, Dr. Ekta Gupta. She is the professor and head of clinical virology, Institute of Liver and Biliary Sciences. Ma'am has done her medical education from Government Medical College, Kanpur, and went on to do her specialization in medical microbiology from King's George Medical College, Lucknow. She has received the Best Scientist Award and a gold medal for the outstanding contribution in clinical research by ICMR. She is well published and has published about over 100 scientific papers in international and national journals. She is the course faculty for the WHO CC at the Institute, and her major research interests lie in hepatitis viruses, transplant viruses, and dengue viruses. A very warm welcome to you, Dr. Ekta, and over to you, ma'am.
Okay. Okay. Good evening. Can you hear me, Namrata? Thank you for your introduction. Can you hear me?
Yes, ma'am. Yes, ma'am.
Okay.
You're audible.
Okay. So I think a very good evening to all of you. I'll share my screen also, and I think most of my talk is, my job has been made easier as Dr. Kapil has very nicely explained about each hepatitis. So I'll be talking about the National Viral Hepatitis Control Program, and most of you are, I think, ILBS nursing faculty. So we've been talking. This has already been stressed. So I'll just start to those who are here in ILBS, that as Namrata has mentioned about Dr. Serene, he's been instrumental, and since 2007 we've been working along with him, and our main aim for this institute was that world-class center in viral hepatitis and liver diseases. So in the year when we started it in 2008, that was an era when HIV infection was was very, very dominant in our country. And as institute grew, so was the problem. It is not that our institute spread, but problem of realization of hepatitis B and C globally was also felt a lot. And since we were the isolated liver disease, specialized liver disease institute, when this problem was felt that something needs to be done for hepatitis, viral hepatitis, I think ILBS was the first forerunner institute which came in the minds of Government of India, and they made a WHO collaborative center in the year 2012 with us. And after that, global health sector strategy and all those things, fortunately for us, that need for hepatitis B and C and work to be done towards viral hepatitis was also felt globally. And these are the targets. I think Dr. Kapil has already touched upon them, that these were the targets set by WHO. So whenever any infections need is felt globally, then WHO comes up with the targets and timeline, what to do by each country till what time. So for hepatitis B and C, control of this problem, they said that each country has to work on hepatitis B vaccination, as we all know that the percentage coverage needs to be increased to 90%, but it was quite high. It was okay at 84. Prevention of mother-to-child transmission was one area which WHO felt that each country need to upscale. And here the role of nursing students and future nurses is there, because in India, the problem of institutional deliveries are there. And I think not all deliveries are done institutionally. And that is why administration of at birth vaccination when a child is born within 12 hours is a difficult task, and which we want that with the help of nursing people and those who are working in the districts and peripheral health sectors, they should encourage more and more institutional deliveries. Blood safety, injection safety were not felt as a problem. The problem was felt was in offering hepatitis B and C diagnosis. You can see that only 9% and 20% were offered, which had to be increased by 90% by the year 2030. And that is why if you will diagnose more, you will put them into treatment. So this was a major problem which was felt globally, the need to have more and more testing facility for hepatitis B and C. And this sir has already said, but only things that when baseline data was calculated, and ILVS had a good role in it in the year 2012 and 13, along with WHO, it was felt that there is a huge problem of B and C in our country, and it is not well documented. So you require a well documented action plan to combat this problem. So this was what ILBS under the mentorship of Dr. Serene we did. And Ajit is there, who was there with me earlier, and after, in all these consultative meetings, we did all these meetings in the year 2014. So ILBA started working on this problem from 2014, 14, 15, 16, and 17. We did these meetings on 28th. Most of you who were there must have been a part of these programs, which were done on 28th of July on World Hepatitis Day. And finally, this was also launched. I think quite a lot of us also went to the Parliament for the release of these guidelines. These are the National Viral Hepatitis Control Program guidelines, which have been launched by Government of India. And now the states, the rolling of this National Viral Hepatitis Program has started. So the aims of this, so there is a program. So as the need was felt that you have a program for tuberculosis, you have a program for malaria, you have a program for HIV, so viral hepatitis is also a problem, please make a program. And so the Government of India made this program, and they kept few targets very clear. Hepatitis C has to be eliminated by 2030. So identify, treat, and remove this problem. B and C, both their infected population, their morbidity needs to be decreased. And then if there are morbidity and mortality by A and E, it has to be reduced. So in A and E, as Dr. Kapil has said, water and food sanitation and hygiene practices needs to be incorporated. So it is B and C basically for which diagnosis and treatment cascade is made. So this program, which is called as National Viral Hepatitis Control Program, is controlled in the central government of India through National Health Mission. You have a National Viral Hepatitis Management Unit. So Secretary of Health, he holds the program, and there are technical resource groups which decide, and they do timely meetings. Now, what need to be done? Fortunately, I'm a part of 2 of these technical resource groups in this national program. Now, then this program goes to each state. So Delhi state has also made a state viral hepatitis management unit, and I'm also a part of this committee. And very soon we are going to come up in Delhi, which place is going to be the state lab, and which all sites are going to be model treatment center. Now, when a hospital will be identified as a state lab or as a model treatment center, there are a set of activity they have to do under this program, because idea is that you bring more and more patients like general population, screen them for B and C, treat them and follow them up so that C is eliminated and B is controlled. So here in this program, Now, if a hospital turns out to be a model treatment center or a state viral lab, the testing for B and C will be done by simple serological card test. Archana would be telling about what are the various type of tests. So we know, and all of you are aware of how HIV is tested B and C. So you can do ELISA, you can do other sophisticated tests, but simple, just pricking the finger and using the whole blood and putting it onto that strip and testing for the presence and absence of antigen or antibodies, a rapid card test. It has a very good specificity, means if it is positive, 100% positive. Yes, the sensitivity is to the tune of 60 to 70, so might miss 20 to 30% cases, but then it is the cheapest and the fastest method by you can screen a lot of people. Now, once a person will be tested by serological, turns out to be B or C positive, the active infection has to be confirmed by a molecular test, which is a PCR test. PCR test is a real-time PCR-based test, and this is also available at most of the centers. So DNA and RNA, HBV DNA, HCV RNA will be done. And depending upon the guidelines and algorithm, which I'll be telling you, if a patient is uncomplicated, means the liver is normal, there is no cirrhosis, in that case, simple treatment can be given for B and C. If B, I'll tell you if they require treatment for B, and can be managed at a very primary health center level. So sophisticated medical colleges, etc., may not be considered for uncomplicated. But center like ours, like a liver center, or like GB Pant Hospital, or like MAMC, where you have facilities for radiology, endoscopy, gastroenterology setup, there the complicated cases can be managed. So they will be made as a model treatment center. So the simple flow chart of working in this program is that you screen every person for B and C, confirmed by HBV DNA, HCV RNA. If it is a simple uncomplicated case, just give treatment and follow up. If it is a complicated case, then you refer it to a medical college or a model treatment center, wherever a good facility of doing an endoscopy or a radiology is also available. This is just a same thing telling you what is a rapid card test. So it is like this flow through. This is based on the lateral flow assay. So lateral flow we call because you put the sample here and laterally it flows and goes and binds. So if it is an antigen detection, there will be antibody blotted and the antigen binds and a band comes on the test line. If it is an antibody assay, the antigen will be bound and antibody binds to it. So it's just flows like this. So this is a lateral flow card. You also have certain spot card which are known as flow through. So there are different technology and different names. Then you have more sophisticated, which are more sensitive assays like enzyme-linked immunosorbent and CLIA, which will be there at slightly higher level of the labs. And then facility for PCR or genotyping will be there at, again, a step higher level of lab, wherever a viral load testing facility is available. So for diagnosis under this program, at the sub-district level, only rapid card screening will be done. At the district level, they will, if you have an access to RT-PCR, the reagents can be made available to you, or cost can be reimbursed if you are outsourcing to a private lab. If you are a state level lab, then again, you should have sophisticated tests like CLIA also, because in certain discordant cases, you should be able to do a diagnosis by CLIA. If you are a center of excellence, then you should have the facility even for sequencing, like certain genotyping if it is needed. So this is just to tell you that in this National Viral Hepatitis Program, what is going to be done at what level. So you have a mohalla clinic or a dispensary, you will just do screening. District hospitals, you have, you know, in Delhi, you are 11 districts and you have hospitals in each district. They can do RDT and ELISA. Then there'll be 2 or 1, I don't know how many state level labs where you will have CLIA, etc. available in RT-PCR. So the sample can go to them and they will report. And then you can have one center of excellence where all the facility is available till the sequencing, so that even all difficult cases to diagnose can be done, the diagnosis. Here, the treatment is that at the mohalla level clinic, at the dispensaries, the drugs will be made available for B and C. There'll be a medical officer made in charge. And if a person turns out to be viral load positive, the treatment as per the guidelines, which I'm going to tell you, will be given. In the district hospitals, the facility should be there for management of uncomplicated cases. So like once you put the patient on treatment, then you require certain biochemical tests like prothrombin INR test or kidney function test, or they should be available. So a simple biochemistry lab, if it is there, then you can actually manage these cases and do a follow-up. But if it is a complicated case, as I told you, the facility for endoscopy and radiology should be available, then only the complicated cases. So this is very clearly defining. Now it is up to each state where they make these drug dispensing units, where they will make these management of uncomplicated cases, and which all sites they will make the management of complicated cases. So this is what are meetings happening right now in the national program. Each state is trying to make, like in Delhi state, I can say that we have done 2-3 meetings trying to identify where to make these drug dispensement sites, where to make these testing and treatment, both for uncomplicated, which sites to be considered for complicated. Because if once a program is rolled out and the name is given, then all testing treatment for hepatitis B and C will be given free of cost. So this is an important decision which state has to take, and then they has to start doing the treatment for hepatitis in B and C as per the guidelines which have been laid out by under this program. Now, there are a lot of challenges, and that is why repeatedly the meetings are happening. First of the challenge was the happening of this COVID pandemic, which delayed all the efforts. Then is that how to do linkage and continuity, because the manpower support is not given under this program. They will only reimburse reagents and and they will give you drugs. So that is the biggest issue, that how will you keep these manpower of data entry operators and and linkage to care and continuity. Then linking a district site with an RT-PCR site, so that all those who turn out to be serological positive are offered at least a molecular test, and then the patient is not lost and is actively followed up. This is also an important area. Communication of results and management of complicated cases. You really need 2 or 3 dedicated centers in each state which is capable of handling these cases. Like ILBs can manage all kind of complicated cases, but then everything has to be made free of cost if the center is made at ILBs. Now, what are the guidelines? Briefly telling you, hepatitis B virus is a DNA virus. They are too important, although there are many antigens and antibodies. You don't have to worry about them, because HBsAg, which is present at the surface of the viral structure, is an important marker by which you can diagnose active infection. But a candidature for treatment, whether the patient requires treatment or not, is decided by doing an HPV DNA test. As Dr. Kapil has clearly told you, that the most important route of transmission of hepatitis B is mother to child, because if you acquire it from your mother, 95% chances that you will land up into chronic infection. If you acquire it at adult, your immune system is capable of clearing the virus. So if the immune system clears the virus within 6 months, then it is acute infection, and you don't have to do anything. Only thing you have to worry is 1% cases might land up into acute liver failure. But it is a problematic area is chronic infection, because once the virus enters, it doesn't leave a person's liver. It goes and binds into the liver in the form of integrated and gets integrated into the host genome. So it resides lifelong, and it's a silent killer. So it's there inside your liver, and whatever medication you do, so just have to monitor. That is why the debate is of long term. So in hepatitis B, you give a long term treatment that is lifelong. Now, under the program, if any person comes out to be HbSAg positive, we are just going to see for the liver health, whether the liver is normal, healthy, or cirrhotic. You can look for cirrhosis by a lot of ways. The gold standard is liver biopsy, but it is invasive, so it is not done. So you can do an ultrasound, you can do a fibroscan, you can calculate by certain scores like Apri score, and you can find out whether the person's liver is in good shape, is cirrhotic or not. Now, if HbSAg positive and cirrhotic, you have to initiate patient on treatment. Recommended treatment is nucleoside analog and oral tenofovir or entecavir, which is given. And then once you put the patient on treatment, treatment is given lifelong. And you have to, once a patient is on treatment, you have to call the patient every 3 monthly and do an DNA, or sometimes some clinicians also do e-antigen, which is acceptable, but DNA needs to be done to know that the treatment is effective and DNA is negative in that patient. Now, if the patient's liver is non-cirrhotic, in that case, we try to look for ALT. You all know ALT is a marker of liver hepatic cell death, because so the liver function test constitutes of ALT, AST, AP, and GGT. ALT, AST, I think all are nursing students, and you should know that they are the markers of hepatic inflammation. So whenever your hepatocyte damage is there, ALT, AST will rise. And a marker of acute hepatitis is when the ALT levels are 4 times the upper limit of normal. So the upper limit of normal is usually 40 international units. So if the markers are very, very raised, that means your ALT is abnormal and there is a problem happening. Now, if ALTs are persistently abnormal and DNA is also very high, normally we report DNA in international units per ml. It's more than 4 log, you have to start treatment. Where you do not start treatment, you defer and just monitor if your ALT is normal and your DNA is less than 2000. Then you just keep calling the patient, do an ALT and DNA to monitor for requirement. So these are the drugs which are given, and they are all available at free cost, at free of cost under this program. They are procured by the National Health Mission, and they will be given to each state. Tenofovir, both the combination TDF and TAF, and entecavir is available. This is in case your center becomes a treatment center. The patient can just walk in, get an HbSAg done, enrolls himself. You just have to check for cirrhosis, then offer a treatment card, and then you start giving treatment or a follow-up testing advice. So if a patient enrolls himself under this program, then all tests, all treatment, all follow-up check has to be done at free of cost. And all this reimbursement can be done by your state health mission under the program. Hepatitis C virus is a simpler virus. It is an RNA virus, so it has very limited number of proteins. So it is the envelope antigen, but you do not see this antigen. We checked for antibody to this antigen, which is known as antibody to HCV, which is a marker of infection. And confirmation of infection, you all know, is done as HCV RNA, because in hepatitis C, we do not treat antibody, we treat RNA. So there can be chances. So in 20 to 30% chance, the antibody is there, but RNA on its own gets cleared. So in this case, you don't have to treat. So it's the 70% cases where antibody is there and RNA is also there. There you have to treat the patient. So you have to do antibody, you have to do an RNA, any RNA, treat the patient. And how do you treat? We look for, again, cirrhotic, non-cirrhotic, compensated, decompensated, and you give. These are all oral antivirals which are now available. So no interferon, sofosbuvir, and declatasvir or velpatasvir. So how to remember? Buvirs are the drug which block the NS5B region of the virus. Asavirs are the drug that block the NS5A region of the virus. So a combination of 5B, 5A blockers, buvirs and declatasvirs, and the treatment is given for 12 weeks. And sorry. So the treatment is given for 12 weeks. And then after 12 weeks of the treatment, you wait for 12 weeks and then look for a sustained. So virus clearance may be there at the end of the treatment, but then we'll have to look for a sustained response. So we wait for 12 weeks more and then just do one time HCV RNA, which is known as SVR12 check. So you don't have to do weekly or twice 15 days RNA. You just have to do once HCV RNA. Genotyping is not done, is not recommended under this program. Only in case you have certain treatment failure, you're suspecting a complicated case, you need to look for a genotype for a treatment combination or to do a resistance workup, you'd have to do, but not in all. So genotyping is not done. So in this program for HCV, the patient walks in, you just have to get an antibody done, then viral load, any viral load, you register, give a 12-week treatment in 28-day divided doses. And then once the patient has finished a 12-week course of the treatment or 24-week, you wait for 12 weeks, that is 3 months again, and call him for a SVR test and look for the viral clearance. Hepatitis E is also there in the program, but only for diagnosing the acute ongoing infection, which we know is checked by this IgM antibody test. And acute, so the patient in hepatitis B, as you can see, the patient is always jaundiced. So clinically, peak of jaundice matches with your IgM. So you can do this IgM assay and look for infection. Similarly, in HIV infection, when you know that the peak of jaundice matches with IgM, and so a diagnosis of hepatitis A in an ongoing jaundice patient is made by hepatitis A antibody, IgM type of antibody assay. So this is how, so if your patient is jaundiced and he walks in for under the program, you're going to look for A, E, B, and C all. And A, we just do IgM, E, IgM. For B, we will do HBsAg, as well as core IgM, and C will do antibody. So, and if the patient is not without no jaundice, that is asymptomatic or no jaundice, in that case, we will only do B and C, surface antigen for B and antibody test for C, the way I have told you. So what is the current status? Current status is that more than a lot of states have taken up this program. 710 centers have been made in different states, and smaller kind of state level projects and programming has been done. In Delhi, we are doing a lot of meetings to make, so it is not still decided that which all sites are going to be treatment sites, where a model treatment center, where a state viral. So these meetings are going on. So I'll just summarize that this is a program which has started in 2018, and it aims to eliminate hepatitis C by 2030, reduce infections of both C and B, and we need to increase the uptake of diagnostics for viral hepatitis, especially B and C. And each state has to make its program and put proposal to their state health mission for coordination with the national program. Thank you.
Thank you so much, Dr. Ekta, for a very comprehensive and a yet very insightful presentation, especially taking us through the systemic action plan towards prevention of viral hepatitis, and very categorically dispelling the market-driven myth around the genotyping hysteria. So thank you so much for covering those aspects of the testing and also the prevention. And it wouldn't be an exaggeration to say that ma'am is one of the forerunners of being instrumental resource in our fight against viral hepatitis. Allow me to now invite, thank you so much, ma'am. May I now kindly invite Dr. Ajit Singh Badoria, Associate Professor, Community Medicine and Family Medicine, AIMS Rishikesh. Sir did his graduation from GRMC Gwalior, and he did his specialization in community medicine from NSC BMC Jabalpur. He holds an experience of over 5 years at the Apex Institute in Liver Disorders, that is ILBS, as an epidemiologist and project coordinator to the WHO Collaborating Center on Viral Hepatitis. Viral hepatitis being his key research area, He is well published in more than 100 scientific journals, and including publications in the Lancet and the Lancet Gastrohepatology. He is the recipient of prestigious ICMR Professor B.C. Srivastava Award in the year 2016. He also serves as the nodal officer for the National Viral Hepatitis Program and is now the managing editor of Journal of Medical Evidence. With WHO headquarters, global hepatitis team, he has contributing in the guideline development group, member of hepatitis C self-testing, technical working group of the HCV self-testing, and developing SOP for enhanced reporting of acute hepatitis cases as scientific committee member from CRO. I very warmly welcome you, sir, and over to you.
Thank you so much. Thank you, dear, for your kind introduction. And a warm good afternoon to all of you. And I'm very thankful to Umesh Kapil sir, who is a mentor and guide for me since the beginning of my career, for giving me this opportunity to be a part of this useful series of webinar. And right now I'm again back to my own Institute of Liver and Biliary Sciences, back to, I'm happy to see George ma'am again. So, this is again an opportunity to talk to my colleagues. And I know that most of you are well aware about, I'll say almost everything about liver diseases. So this is something which is a revision for you. And Dr. Umesh Kapil sir, Dr. Ekta ma'am, they've already told you everything about viral hepatitis, mainly that you should know as a nurse. So what I'll do, I'll be briefly talking about the modes of transmission and how we can prevent this transmission so that we can break the chain of transmission and we can decrease the number of new cases which occur for hepatitis B and hepatitis C. Is my slides visible? Okay, I hope yes. So I'll be telling you about modes of transmission for hepatitis B and hepatitis C, and then I'll tell you about what could be the possible most effective strategies to prevent this transmission. We know about general precautions. We know about universal precautions. We'll talk about them in the subsequent slides. We know about the importance of vaccination to prevent hepatitis B transmission. And then we'll talk about post-exposure prophylaxis, which, being a healthcare worker, we are exposed to the risk of needle stick injury. And sometimes we need this PEP so that we can prevent this hepatitis B infection among healthcare workers. So as already discussed, this is something which is a revision. Hepatitis A and E, first one and last one, they are enterically transmitted. That means they are transmitted through fecal-oral route. Then B, C, and D, they are parentally transmitted. That means they are transmitted through unsafe blood or through unsafe injection practices or through unsafe sex or through, as an occupational hazard. So B, C, D, they are parentally transmitted. Why D? We are not talking much about D because, as it was told by Umesh Kapil sir also, D is a defective virus. It never comes alone. It always comes with hepatitis B, either as a co-infection, both occurring together, or as a super infection, the D occurring on hepatitis B, already existing hepatitis B infection. So these are the 5 hepatitis virus. Hepat means liver, itis means inflammation. Viruses which causes inflammation in the liver, causes liver disease. They are hepatitis.
raise hand wala gesture hota hai na?
So could you switch your presentation on full screen mode, as the slides are not progressing on the screen?
Okay,
you could maybe hit F5
again. Let me again.
You could maybe just hit F5. I'm sorry for the interruption though.
It's okay. Now it's coming. Lecture chal raha baat.
Maybe there's a transmission delay.
Now is it
just
coming?
give me a word.
Okay.
No, sir.
No. Because I'm moving my slides in slide share mode only.
Could one of our participants kindly respond if they can view the slides? We don't see the slides moving on the panel.
The slides are not moving. Namrata, you have the slides. You can project them if you have them right now.
Sure.
Now they are moving or not?
No, sir, they're not
No.
moving. I
So
think.
Okay.
I'll be sharing from my system here. Requesting a kind patience.
Right. So I was talking about that there are 5 types of viruses. A and E, first and last one, they are fecal, and B, C, D, they are parentally transmitted. So when we talk about parental transmission, that means mainly unsafe blood, which can be due to transfusion of unsafe blood or unsafe blood products. It may be due to hemodialysis, or it may be due to multiple transfusion in some group of patients. And it may be due to unsafe injection practices in a particular healthcare setting, or maybe due to surgeries or some procedures like dental procedures or small daycare surgeries. So at these point of times, sometimes there might be exposure to a contaminated or infected blood, and the chances of transmission is more. Other than blood and blood products, the transmission can be due to unsafe sex, similar to HIV. So that is also common, and that is also seen for both hepatitis B and hepatitis C, but lesser than HIV. Then other than sex, it may be due to sometimes sharing of needles among those who inject drugs. Right? So people who inject drugs, or we sometimes call them intravenous drug users. So what they do, they share needles. So when they share needles, the chances of transmission of hepatitis B, hepatitis C, along with HIV increases. Right? And then one other one is vertical transmission. So this third point, perinatal transmission or vertical transmission. This one is most common mode of transmission for hepatitis B. So mother to child transmission is mainly in hepatitis B, when mother is infected, and this hepatitis B virus then is transmitted to the newborn. So vertical transmission is important for hepatitis B. Bloodborne, the first part which I've already explained, sharing of needles among people who inject drug, that is most common mode of transmission for hepatitis C. And the last one, horizontal transmission, is common in both hepatitis B and hepatitis C. That is inapparent horizontal transmission. That means sometimes sharing toothbrush, sharing razors, there might be some exposure of infected blood to one another among the close contacts, that can also lead to transmission of hepatitis B and C. Next slide, please. It's not moving. Next slide. Yeah. So in this slide, the main focus is to just tell you about hepatitis B. All route of transmission, they are same, but you have to just remember that mother to child transmission is the most common route of transmission for hepatitis B. Next slide. So this slide is very important, which makes you understand the timing of hepatitis B infection. If it is occurring at birth, then the chances of this infection converting into chronic infection is about 90%. So if an infant, if in early childhood there is an infection occurs, then chances of converting this infection into chronic infection is around 90%. This decreases with the age at infection. So if the infection occurs late, chances of chronic infections decreases, but the chances of symptomatic infection, that is dotted line, that increases. So there may be a chance of having acute hepatitis B. So other than hepatitis A and hepatitis E, acute hepatitis B is also common if it occurs in the later years of life. Next slide, please. So preventive strategies, vaccination is the most effective, most cost effective, and the best strategy for hepatitis B infection prevention. So it can be given as a childhood vaccination in our universal immunization program. We are giving it, and this is in 2 forms. One is a timely birth dose, when birth dose is given within 24 hours, and second is primary 3-dose vaccination, which are given at 6 weeks, 10 weeks, and 14 weeks of infancy. So if we give birth dose and all these three doses, then the protection level increases, and the chances of this particular person or child to get infection in the future is almost nil. So vaccination is the most important strategy, and this strategy is also important for us, for nurses, for healthcare workers. Like if we can vaccinate our healthcare workers, nurses, I hope all of you are vaccinated for hepatitis B. I hope all of you have checked your antibody titers also, hepatitis B surface antigen antibody titers. because that's very important to confirm that you are safe from hepatitis B transmission. So this is important in healthcare workers. Vaccination is also an important strategy in high risk groups also. So other measures there on the right side, screening of blood, safe injections, occupational safety, harm reduction, they are similar to the for prevention of hepatitis B also, hepatitis C also, and for HIV also. But if somebody asks you which is the most important strategy for hepatitis B, it's vaccination. Next slide, please. So antibody titer I have already explained to you. If any time in your life your antibody titer is more than 10, that means be assured that you are protective. You are protected against hepatitis B infection. No need to go for any booster. No need to go for any other intervention if it drops any time in your life. Next slide, please. So this is the coverage of 3 doses. It's more than 80%. That's good thing. Our target is that it should be around 90%. I mean, I'll say 90% or more than 90% by 2030. So we can easily achieve this target, because this is in our universal immunization program since last more than 20 years. Next. So what is the impact of why we are emphasizing on vaccination? So you can see blue line tells you about 3 doses of vaccine. Orange line tells you about birth dose. So with increase in the coverage of 3 doses of hepatitis B vaccine, with increase in the coverage of birth dose of hepatitis B vaccine, you can see the decline in number of chronic cases, black line, which is going down from 50 lakh to only 5 lakh from 1990 to 2014 as the coverage of hepatitis B vaccine increases. So more vaccine, less infections. Next slide, please. So this graph has already been explained to you. This just tells you about the importance of birth dose. So if we can give birth dose, we can prevent mother to child transmission. We can prevent early infection. We can prevent converting that early infection into chronic infection. We can prevent converting of this chronic infection into cirrhosis or liver cancers in the later part of life. So what is this timely birth dose? Next slide. So timely birth dose means that we need to give hepatitis B birth dose within 24 hours of birth. So that's what I want to tell you about timely birth dose, that every newborn should get a hepatitis B vaccine within 24 hours of birth. So see the third line, birth dose followed by at least 2 doses of hepatitis B vaccine can effectively prevent mother to child transmission in 90% of cases. So that means it's the most important and the most dynamic strategy to prevent hepatitis B transmission. So what is the coverage of this birth dose? This is very poor. It is around 38% globally. The target is to achieve 90%. So this is something where we have to work upon. We want that all deliveries should occur in institute. All newborn should get a birth dose if we want to prevent mother to child transmission. So why this mother to child transmission is common in India or common in developing countries? There are multiple reasons, and one is high birth rate. Second is poor antenatal care. Then poor birth hygiene, and chances of transmission is more. Poor coverage of hepatitis B birth dose, only 38% globally. High population density. Excess use of injections for minor childhood illness may also transmit infection. And if the infection is occurring early in childhood, then chances of chronic infection increases. Then what could be the possible strategy? Every pregnant mother should be screened for hepatitis B surface antigen. Every newborn should get a birth dose. Every newborn who is born to a mother with hepatitis B infection should also get a hepatitis B immunoglobulin within 48 hours of birth. So if we talk about transmission route in hepatitis C, they are all similar. All parental transmission methods, they are mentioned in this slide, but you should know that most common mode of transmission is unsafe blood and unsafe injections. It can be unsafe injections in a healthcare setting, or it can be unsafe injection practices among people who inject drugs, who share needles, right? So these are the important modes of transmission for hepatitis C, other than tattoo, body piercing in a particular tribal population and in a particular group. So we have to train them so that we can block their transmission also, other than unprotected sex. In some cases, mother to child transmission, and in some cases, inapparent horizontal transmission also by sharing razors, toothbrushes among close contacts. Next slide. So how to prevent hepatitis C? So hepatitis C can be prevented by universal precautions, by safe blood, safe injection, harm reduction intervention. We'll talk about harm reduction intervention in the last slide. Then safe sex and occupational safety. And also we know that we do not have a vaccine for hepatitis C. We have a good vaccine for hepatitis B, but we do not have a vaccine for hepatitis C. Then how we can prevent hepatitis C? So the most important strategy, which I feel, is test and treat. So if we know that 95% of hepatitis C individuals, they are asymptomatic, they do not know that they are infected to hepatitis C, they are living normal life in the community and transmitting infection. So if we can go and find these missing millions by testing them, by increasing the testing or screening uptake, we can at least identify and treat them, because now we have simple oral drugs which can safely cure this disease. Then prevention of nosocomial transmission is important strategy, not only for hepatitis B, but also for hepatitis C and HIV. So we have to follow hand hygiene practices, safe handling and disposal of sharps. Biomedical waste management is important. We have to follow it. We know that there's a rule and law in our country to follow biomedical waste management. Safe cleaning of equipments, screening of donated blood, safe blood, and training of health personnel. So everybody who joins our healthcare settings, they undergo training of universal health, universal precautions, training of needle stick injuries, training of biomedical waste management. The main agenda behind such training is so that we can make them work in a safe environment without getting infected and without transmitting infection to others. Next slide. So other thing which is also very important, the most important high risk groups for hepatitis C and hepatitis B is people who inject drug. So how we can prevent this transmission among this group? We can offer vaccination. We know that vaccination works very nicely. Second is we can even provide incentives also. If they go for all 3 doses of hepatitis B vaccine, we can provide them. So this is harm reduction. Harm reduction is providing free sterile needle and syringes to these group so that they can avoid sharing of needles and so that they can be safe, guarded from transmission of hepatitis B and hepatitis C. Opioid substitution therapy can also help because we know that they are opioid dependent. So if we treat the cause, we can make them safe, or we can take them out from this particular group of high risk group for hepatitis C and hepatitis B and HIV transmission. Then we can integrate treatment of opioid dependence with medical services. I mean, they can simultaneously be treated for hepatitis also, for this opioid dependence also. Safe sex is important strategy not only for HIV but also for hepatitis B and hepatitis C. So correct and consistent condom use, routine testing of those who are involved in high risk or unsafe sex practices, mainly sex workers. So if they can be routinely tested, and if somebody is infected, can be treated, that can help as a good strategy. Integrating integrating the actions with eliminating discrimination. So as was talked by Dr. Umesh Kapil sir, we have to eliminate discrimination for hepatitis B, hepatitis C, for HIV patient, and also for those who are sex workers. There should be no discrimination. There should be no gender violence. They should be approached, given free testing. They should be provided with whatever help is required so that at least they can live a healthy life, and they should not transmit hepatitis B, HIV, or hepatitis C to others. So this slide is very important. This is basically from the policymaker point of view. These are the ultimate targets for hepatitis B and hepatitis C elimination. So if we want to eliminate viral hepatitis, we have to reduce incidence by 90%, and we have to reduce mortality by 65%. So how to reduce incidence by 90%? This can be done by these 5 strategies. First is by increasing 3-dose hepatitis B vaccine coverage to 90%, increasing birth dose coverage from 34% to 90%, safe blood to 100%, unsafe injections should drop from 5.2% to 0%, and harm reduction, that means providing free injection sets, that means sterile syringe and needles to people who inject drug, around 300 per year per person. If we can increase this number of provision of these sterile injection sets, then we can reduce the incidence of hepatitis B and hepatitis C by 90%. So this is important slide which makes you understand about the preventive strategies also, and makes you understand about the targets which are set by global health sector strategy, that if this is done, we can achieve 90% reduction in incidence. Next slide. So to summarize, hepatitis B and C both are parentally transmitted. Hepatitis B mainly by mother to child transmission, hepatitis C mainly by unsafe injection and unsafe blood. To prevent hepatitis B infection early in life, mother to child prevention is important, because we know that if hepatitis B infection occurs early, then there is more than 90% chance of converting it into chronic infection. Vaccination is the most effective preventive measure for hepatitis B. So both birth dose and 3 doses, the coverage should be more than 90% if you want to block mother to child transmission. Antibody titer, especially for nurses, especially for healthcare workers, is important indicator, important marker to know that you are adequately protected against hepatitis B. And other than this, safe blood, safe injection, and safe sex, they can also be a useful tool to prevent hepatitis B and hepatitis C transmission. Last, I'll also like to add test and treat policy. So if we can test and treat these asymptomatic hepatitis B and hepatitis C cases, that can also act as an important blockage of transmission of this disease in the population. So thank you so much. That's all from my side, and we'll take questions in the panel discussion session.
Thank you so much, Dr. Ajit, and really comprehensively summed up, but really you picked up indeed the vital points and aspects of the transmission of viral hepatitis. And I'm sure our students of the nursing college would appreciate that their job roles they have necessary overlaps, and in a country that lives in its villages, a nursing service personnel would be dealing with a lot of regional and remote rural area practices as well. And they would be playing a key instrumental role in stopping the transmission, especially the vertical transmission and the needle stick injury and transmission through the drug usages, and will be able to counsel the patients better now. Thank you so much. May I now please welcome Dr. Archana Ramalingam, the next speaker for the day. She is the scientist E, ICMR NIE Chennai, and ma'am did her graduation from JIPMER Pondicherry. She went on to do her specialization in community medicine from the same institute at Pondicherry. She is the recipient of Professor R.K. Kar Best Postgraduate and is a gold medalist in Community Medicine Award in 2014. Ma'am has worked in multiple research projects at JIPMER, Pondicherry, and MAMC New Delhi, and also at the ILBS. She has been a resource person for several workshops on research methodology and basic epidemiology. She is also the recipient of IAPSM Ford Foundation Epidemiology Grant and has been awarded the prestigious she has been awarded for best oral papers in several conferences, including the IPHA and Jericon. Her areas of interest include non-communicable diseases and viral hepatitis, along with community-based interventions, health promotion, and medical education. She is well published and has several articles in national and international journals of much reputation. So very, very warm welcome, ma'am. Over to you.
Thank you so much for that kind introduction, and good afternoon to everybody. And it's indeed a pleasure to get back to ILBS and be there with you to talk to you about this all-important topic of prevention and control of viral hepatitis. So without speaking much, I'm sure the previous speakers have already covered all the important areas. I will just share my screen and then talk to you briefly and summarize about my topic for today. So could you please confirm if my screen is visible and I'm audible?
Yes, ma'am, you're audible and we can see the screen as well.
Okay, thank you so much. So the topic given to me today is to discuss with you about screening, vaccination, and health education, particularly in the context of viral hepatitis B and C. And so I'm sure the eminent speakers before me have already appraised you and have discussed with you about all of these aspects. So I will not be, wasting your time and discussing it in detail. I'll just summarize the key important take-home messages for all of you. So when we look at screening for hepatitis B and C, as you may be aware by now, anyone who walks into a clinic, even at the most peripheral level, needs to be offered services for hepatitis B and C if he or she demands for the same. And this we are planning to achieve through the new National Viral Hepatitis Control Program. And that is going to be operational at all levels, starting from Health Wellness Center, PHCs, right up to district hospitals. And then there will be linkages and referral linkages to model treatment centers and centers of excellence. So anyone who walks into any site should be offered testing services if they demand for it. And then the preference, of course, should be given to individuals who are at high risk. Having looked at the transmission dynamics and how transmission happens for B and C, you already are aware about the high-risk groups which require priority screening. And these are pregnant women, people who use injection drugs, healthcare professionals, you, me, everyone who's part of this call, people who undergo hemodialysis, as well as patients of HIV and individuals who are at high risk for HIV, like the men who have sex with men and commercial sex workers. In addition to these groups, there are also certain other groups which need to be targeted, like close family contacts of B and C patients, and also individuals who go and get themselves tattooed from unsterile parlors. So I'm sure Ekta ma'am has talked to you about the various screening and confirmatory tests. Just to again reinforce, for hepatitis B virus, we use a rapid card test which follows the principle of lateral immunoassay and detects hepatitis B surface antigen. Whereas for C, again, we use the same principle, but what we intend to detect for the screening test is antibodies to hepatitis C virus. So the take-home message is the screening test that we use for B is detecting HBsAg, and the screening test for C looks at anti-HCV. Of course, this I would not go into detail. I'm sure all of you at ILBS have already seen this and done a rapid card test, probably, or would be doing in your future training. And these are simple to use, easy, disposable, and can give you results within 15 to 30 minutes. And they are having very high sensitivity and specificity, and therefore can be used definitely for screening within the national program. And the national program does have an goal to introduce these even at the most peripheral levels. So this is what I wanted to discuss with you about screening. So we need to be aware of what are the screening tests we use and their sensitivity, specificity, and who are the individuals who would require priority screening if you are offering screening services to a community. When we come to vaccination, of course, Dr. Ajit and even I'm sure Professor Kapil has already discussed with you the importance of vaccination for hepatitis B virus. Now, we do have a very safe and efficacious vaccine for hepatitis B virus. The protective efficacy, if you give all the 3 doses, is quite high. And the key area that needs focus right now is the birth dose vaccination. So quickly to run you through, hepatitis B vaccine is a recombinant vaccine, and this contains a protein, which is the hepatitis B surface antigen. And this recombinant vaccine, the protein is produced by introducing the genes into the yeast and mammalian cells and culturing them. And there are several types of hepatitis B vaccines. Mostly when we vaccinate adults, we use monovalent single antigen vaccine, and the common brand that is used in India is Engerix B. When you look at vaccination of infants and children, usually the government of India through the Universal Immunization Program recommends a combination vaccine, which is called as a pentavalent vaccine. Now, this vaccine, in addition to hepatitis B, also offers protection against diphtheria, tetanus, pertussis, and Haemophilus influenzae B. Now, you must understand the vaccine schedule for a monovalent vaccine, which is the first one that I discussed, and a pentavalent vaccine is slightly different to give better efficacy for all the diseases that they cover. If you move to the private sector, most of the private pediatric practitioners in the country offer something called as the hexavalent vaccine, which is in addition to the 5 diseases that I mentioned in the previous that I mentioned just now to you. It also offers protection against the poliovirus. So IPV is the other addition to whatever is there in the pentavalent vaccine. So these are the common types of hepatitis B vaccines that we have in India. And these are very good, they have got very good stability and can be easily stored in an ice-lined refrigerator. The only point to note is they are very sensitive to freezing. When we look at the dosage is very high for hemodialysis and immunocompromised patients, that is about 2 ml, whereas for infants and children, the common dose is 0.5, and for adults, it is 1 ml. Now, the schedule is something that you need to remember, and this is an important take-home message. So for any newborn or childhood vaccination, the schedule that is followed in the universal immunization program is giving a birth dose. So within 24 hours of birth, for every newborn, we must give a monovalent hepatitis B vaccine, that is having only protection against hepatitis B. Whereas when we go for 6, 10, and 14 weeks vaccination, for practical purposes, we give a combination vaccine that in a single shot gives protection against 5 diseases. That is the pentavalent vaccine, which I just talked to you. So the schedule for pentavalent vaccine is 6, 10, and 14 weeks. So for protection against hepatitis B virus, for children, the vaccination schedule is give 1 dose of monovalent vaccine at birth within 24 hours, and then give 3 doses of a combination pentavalent vaccine, which is 6, 10, and 14 weeks. Now, this pentavalent vaccine under the government program can be given up to 1 year of age. And if any child has missed the dose on the appropriate date, then whenever the child remembers, can take the next dose within 1 year. And if the third dose, 1 month apart. When we go to adults, the schedule is 0, 1, and 6 months. And here for adults, usually we give monovalent vaccine, which offers protection only against hepatitis B. And therefore, the schedules are slightly different. And this is something that you need to understand and remember as healthcare providers. I'm sure you will be during the course of your training, as well as when you will be practicing later as nursing professionals, you would be giving this advice and also providing these vaccines to several beneficiaries. Of course, the site of administration, all of you know, for infants and children, it is in the anterolateral aspect of the thigh, and for adults, it's in the deltoid. We generally tend to avoid gluteal muscles for this vaccine. Now, how protective is hepatitis B vaccine? Hepatitis B vaccine is a very efficacious vaccine. If you give all the 3 doses of the combination or even the monovalent vaccine, the efficacy is very high to the tune of 98 to 100%. And even if only 2 doses are given, the efficacy is quite good, 80 to 95%. So it's a very efficacious vaccine, and definitely plays an important role in the efforts for elimination of hepatitis B and for viral hepatitis elimination. So is it just enough to merely get vaccinated? At least as healthcare providers, all of us need to know if vaccination has converted into generation of immunity. So whether vaccination has led to immunogenicity or not. In order to test this, you need to look at your anti-hepatitis B surface antigen titers. So if the titer is more than 10 at any one point in your lifetime, then that defines adequate vaccine response. So I'm sure as you're studying in ILBS, all of you would have already all of you must be vaccinated, I think, as soon as you join the course, or maybe previously also. And I'm sure your titers have been tested. And if your titers are tested and they're more than 10, then you have got adequate vaccine response. And that also indicates that you will be having protection for the next 30 years. And since you will also generate a cell-mediated response, which is not measured through this, you need not get any other booster dose for the rest of your life if you're an immunocompetent person. It is only for the immunocompromised individuals that this needs to be checked again and again. So the take-home message number 2 is an immunocompetent adult who has had the complete schedule of vaccines and who has had an anti-HBs titer of more than 10 at least once in their lifetime. They remain protected for the remainder of their lifetime and really need not go in for a booster dose. Now, what to do for an adult who has forgotten to get the dose on time? So if the schedule is interrupted after the first dose, then the second dose can be administered as soon as the individual remembers that he has missed his vaccine dose or missed the schedule for vaccination. And the appropriate interval for adults who get monovalent vaccines between the second and third dose is about 8 weeks. Whereas if an individual has got the 0 and the first month dose, and only the third dose is missed at the 6th month, whenever he remembers, he can get this dosage administered. Another common problem that you might encounter is individuals who may not remember really whether they have gotten 1 dose or 2 doses, or whether they have completed their schedule, etc. Or sometimes, you might think that their vaccination history is unreliable, if not unavailable. So for these individuals, you can go ahead and give them extra vaccines if you think that they are not sure if they have completed their schedule, because, administering extra doses really is not harmful. So this is one point that I wanted to make. And another important issue is whether we can give hepatitis B vaccine in pregnancy. Of course, you can give. Pregnancy and lactation are not contraindications for hepatitis B vaccine. So specifically, pregnant women who are at high risk, that is if they have a sexual partner who is HBsAg positive, if they are an injection drug user, or if they are getting treated for other STDs, or if they have more than one sex partner, then these pregnant women definitely are at high risk of acquiring hepatitis B virus. And therefore, you should consider vaccinating them if they are not previously vaccinated. When we talk about adverse events, not a lot of adverse events. Most of the reported adverse events are mild, like you can experience a small amount of pain, swelling, or redness at the site of injection, and there could be a small rise in temperature or a headache. However, very rarely, like 1 in 1 million dose, individuals can get severe allergic reactions, and this really is the only contraindication for hepatitis B vaccine. So you can safely administer, another important point that you need to remember is you can safely administer the birth dose to even children who are born prematurely or who have got low birth weight or small for gestational age. You can also safely administer this vaccine to children born to HIV-infected mothers, as well as children who have got neonatal jaundice. So these are not conditions which entail a contraindication for hepatitis B vaccine. And they can be safely co-administered with other childhood or adult vaccines, and there is no interference. Therefore, that also you can do. So the important aspect which Dr. Ajit covered is the WHO's efforts to push for elimination of viral hepatitis by 2030. And this entire effort is called as the Global Health Sector Strategy on Viral Hepatitis. And this aims to eliminate viral hepatitis by the year 2030. Some of the key targets Dr. Ajit might have walked you through, and the important targets specific to vaccination, I would just like you to revise with you again. The specific target for 3-dose vaccination is 90%, and for the birth dose vaccination is also 90%, and we hope to achieve this by the year 2030. Now, where do we really stand? If you look at the 3 doses, primary doses, the Southeast Asian region is doing fairly well. We are having a coverage of about 87%. In the next slide, I'll show you what is the coverage for India as well. Whereas when you look at the birth dose, that is where, as I mentioned previously, concentration is required. All the healthcare workers should definitely put in efforts to increase the birth dose coverage of hepatitis B vaccine. So if you look at 3 doses, the first 3 doses of pentavalent vaccine, the coverage is quite good as per the recent NFHS data. The coverage is more than 80%, so we are doing really well. Whereas the birth dose, which is very, very important. Why is it important? Because this graph, I'm sure Dr. Ajit already has discussed with you. This graph shows you on the x-axis, the age at infection, and on the 2 y-axis, the primary and secondary y-axis, you can see what happens to chronic infection rate and what happens to symptomatic infection percentage based on age at infection. The take-home message, if you really look at this chart carefully, is if you have an infection at a very early age, especially when you acquire it from a person's mother, that is, the infection happens at mother-to-child transmission at birth, the chances of that particular infection going for chronicity is very high. So earlier infection or early age at infection really has got a very high risk for chronic infection. As a result, there should be concerted efforts towards prevention of mother-to-child infection of hepatitis B. And what is the weapon that we have against mother-to-child transmission? And that is really the birth dose of hepatitis B vaccine. So timely birth dose, that is within 24 hours of birth, is very important. And studies have shown that this, followed by 2 or 3 doses of hepatitis B vaccine, effectively prevents mother-to-child transmission in more than 90% of the cases. And as I previously said, though we began administration of birth dose of hepatitis B very early in 2009 itself, even as of today, the coverage is not very good globally, as well as in India, the coverage is roughly about 40 to 45%. So this is where we really need to focus. And just to touch upon hepatitis B immunoglobulin, hepatitis B immunoglobulin is another aspect that can help prevent mother-to-child transmission and usually is given along with the birth dose. The challenges do exist for hepatitis B immunoglobulin in terms of higher cost and limited availability. However, if your center has this and if you plan to give it, you should know that it should be given in different limbs. The vaccine should be given in one limb and the immunoglobulin in the other limb. And you should definitely use different syringes for administering these two. So in summary, vaccination is an important strategy which will help in elimination efforts of viral hepatitis. Giving the 3 doses schedule for all eligible beneficiaries is very important and offers very good efficacious protection. And if you really want to see whether the vaccine has offered you adequate protection, you need to check your anti-HPS titers, and healthcare professionals should definitely test this at least once in their lifetime. And if the value is more than or equal to 10, an immunocompetent individual can be fairly sure that he does not require a booster dose. Now, prevention of mother-to-child transmission is the focus, and one of the key weapons we have for this is birth dose vaccination. And if you give birth dose followed by 2 additional doses, it offers very good protective efficacy against mother-to-child transmission of hepatitis B. Moving on to health education, now ILBS is really spearheading the health education efforts towards elimination of viral hepatitis. And they have used almost all the commonly used modalities for health education. They have created posters, they have run interesting competitions, they have a brand ambassador, they are active on social media and always advocate for viral hepatitis elimination. They run campaigns and have conducted conclaves with key policymakers in the past. Just to run you through some of the efforts of ILBS, ILBS has already created good posters which convey important messages, like one is hepatitis C is curable. And then they have got posters on why pregnant women need to get tested, what is the importance of birth dose vaccine, and also they have got general posters on improving awareness on viral hepatitis. In addition, they conducted a very unique cartoon competition wherein people from over 40 countries participated, and they created really good artwork which can be used for health education of viral hepatitis. And another interesting initiative was the Happy School initiative, wherein all the school principals and teachers from the Delhi government schools were trained and really were made ambassadors in the efforts for elimination of viral hepatitis. And we do have a brand ambassador under the empathy campaign in the form of Mary Com. She constantly tweets and through her social media platforms generates awareness about viral hepatitis. She has even, she has even starred in few of the videos that were created by the empathy campaign. Of course, faculty videos from Professor Sareen and Dr. Ekta have always remained key resources, even for healthcare professionals, and of course for the general public as well, and for really anyone who wants to know about viral hepatitis. And we do keep conducting I Pledge campaigns through the empathy initiative. And of course, key policymakers are always brought on board. And this is a picture with, several parliamentarians who have attended the conclave and trying to just work towards efforts for elimination of viral hepatitis. And the empathy campaign is also very active on social media. All of you are young audience. I'm sure you're active on social media. So you can also check out the Twitter pages and the YouTube pages or the YouTube channel of empathy campaign. So I think that is all I have for you today. And thank you very much for the opportunity. And over to you, organizers.
Thank you so much, Dr. Archana, for a very engaging and a very interactive presentation. And it would not be an over-exaggeration to say that we do have a brand ambassador, but then you do serve as the academic ambassador, touching upon the endeavors that empathy has been doing so far and the knowledge dissemination for viral hepatitis. Thank you so much for a wonderful presentation yet again. May I now request the next speaker for the session, Dr. Mania Prasad, who is the Assistant Professor, Clinical Research Epidemiology, Institute of Liver and Biliary Sciences, New Delhi. She has 35 international and national articles to her credit in Medline indexed journals at such a young age. And also she has facilitated many workshops on research, methodology, evidence-based medicine, and GRADE tool. She is the recipient of gold medal in MD final exam and also the recipient of International Epidemiology Association Fellowship. Her area of interest lie in epidemiology, medical research, systemic reviews, and meta-analysis, and also evidence-based medicine. Thank you so much for being here with us today, ma'am. And over to you, Dr. Mania.
Thank you. Thank you so much, Namrata. And I think without much ado, I'll just get right on to the presentation in the interest of time. What I've been asked to talk about as the final session after all of the participants are already equipped with so much of information is the burden of hepatitis B and C in India. And what I will do is, after providing a brief background on why this is important to think about, and why we should turn our attention to viral hepatitis elimination efforts again, I will provide some reported estimates of the prevalence of chronic infection in India. And this will be followed by a brief academic discussion, you could say, of the review of the current literature on the burden and the burden estimates from recent studies. And I will talk about some data on the rate of liver complications and the risk with hepatitis B and C, and finish off with some steps needed. So you already have all the information you require for prevention and public health measures, but why should we care about this? Because hepatitis is one of the leading causes of mortality worldwide, and it's certainly a very important public health problem in Southeast Asia, of which India is a part. It's one of the communicable diseases where mortality is observed to be increasing. There's some indication that mortality has been increasing, and it's responsible for as many, if not more, deaths annually than TB, AIDS, or malaria. And around 90% of these are due to hepatitis B and C. We also need to think about this seriously because this is a disease that is easily amenable to prevention and control. So we have a very effective vaccine for hepatitis B. We have a cure for hepatitis C and good drugs that can manage hepatitis C. And so this is something that we can actually do something about. In terms of the pandemic, COVID-19 has posed a major challenge in achieving hepatitis elimination. Best by efforts such as vaccination, health education, and screening have suffered a great deal because of the lockdown, because of COVID-19. And it is documented that hepatitis has suffered among the highest destruction of all diseases, which is more than even HIV, malaria, and tuberculosis. And so the momentum has certainly reduced because of the pandemic, and it's about time that we bring our focus back onto this very important disease. Of course, when we talk about the burden of hepatitis B and C, what we're worried about is not just the acute infection. So of course, very often there's just a fever and a jaundice and malaise, and the patient recovers. But what is more serious is chronic hepatitis caused due to B and C infection, which over a period of time leads to irreversible damage in the liver. So with sustained inflammation, there's fibrosis. So the healthy liver tissue gets replaced by scar tissue. And long-standing fibrosis will lead to the irreversible damage and lead to cirrhosis of the liver. And over time, this can lead to cancer, so hepatocellular carcinoma. And so these two complications, cirrhosis and hepatocellular carcinoma, are responsible for a great deal of mortality resulting from hepatitis B and C. And I will provide you with the data for this in the subsequent slides. So if we talk about the worldwide prevalence of hepatitis B, 296 million people are living with chronic hepatitis B and 68 million with chronic hepatitis C. So huge burden there in terms of the chronic infection itself. But in terms of death, viral hepatitis accounted for around 1.4 million deaths worldwide, according to the 2015 WHO estimate. And it's estimated that there were 820,000 deaths in 2019, mostly from cirrhosis and hepatocellular carcinoma. And so, of course, these two liver complications are very serious in terms of the burden. If we talk about the burden of liver complications worldwide a little bit more, up to 40% of patients with chronic HBV develop serious sequelae during their lifetime. And HBV and HCV infections with cirrhosis account for 720,000 of these deaths, and hepatocellular carcinoma for 470,000 deaths worldwide. So again, you can tell huge numbers, big burden globally. So this is the spread of the case burden across the WHO regions. So in total, 296 million. And then there are some regions that are affected more. So the Western Pacific and the African region face the brunt of the burden. But Southeast Asia region, again, 60 million cases. So not a small number. This is for hepatitis B. And for hepatitis C, there are 68 million cases worldwide. And again, Western Pacific, African region, heavy burden, but then also Southeast Asia, 10 million cases of chronic hepatitis C. There are some within the Sero region, there are some countries that are affected more. So Indonesia, Myanmar, Thailand, Bangladesh are among the countries that are facing a higher burden of chronic hepatitis B, which is measured through the prevalence of surface antigen. And similarly for hepatitis C as well, again, Indonesia, Myanmar, and Thailand severely affected. Let's see some specific data for India now. So for the prevalence of chronic hepatitis C infection, there are 3 research groups that have provided some estimates of the overall prevalence. And this is arisen from systematic summaries of the literature. So there have been a number of studies that have tried to estimate the prevalence of chronic hepatitis B, mostly through measurement of surface antigen. And these are the estimates. So the first row is the worldwide, and the second row is for India specifically. And the Schweitzer et al. Paper, which was published in the Lancet in 2016, is purported to be a reliable estimate, which is 1.46%. So that's the point estimate. And then in these brackets, in this table, is the confidence interval. So the way that you can think about confidence interval is like a margin of error. So these are the whole range of plausible values consistent with the data. So that's 1.44 to 1.47. WHO has engaged a number of agencies to estimate the prevalence, and not very different, 1.95% with a large overlap in the confidence interval again. And then there's the CDA Polaris group, which have also done a modeling exercise, and they landed up with a slightly higher estimate of 2.5, with the confidence interval that's again significantly overlapping with the other 2 estimates, that's 2.2 to 2.7. Just a word about what these research groups did. Well, they've all reviewed literature. So they've all done a systematic review and meta-analysis. You can think about systematic review and meta-analysis such as being a study of studies. So they've included a number of published studies. Some have included unpublished studies also. And they've searched all of these different databases. These are all probably avenues that you guys are familiar with because you turn to these when looking for evidence. And so they've all summarized the evidence that's already out there. They differ slightly in the number of countries that they've included. So some included a different list of countries than others. And they differ slightly also in the way they summarized it, so the calibration of the model, etc. But mostly large overlap in the kind of population that they have included. Most of them excluded high-risk populations like migrants, refugees, and non-representative populations. So this is what these research groups did in arriving at that estimate. So the Schweitzer et al. Paper you can quote because this is purported to be a reliable one, and they have said that the prevalence is 1.46%. They included 129 studies and 3.7 million subjects in arriving at this estimate. And that accounts for around 17 million chronic carriers in India. If you compare this to two time periods, that's 1950s to 1980s, compared to a decade later, you can see that the prevalence is reducing. So the trend is a reduction. So 2.62 back then to 1.44 presently. And this could possibly be attributed to the vaccination that's happening. This is also supported by the WHO estimate, which if it is stratified according to pre-vaccination era, and the 2019 estimate again demonstrates a reduction in the prevalence of 2.13 to 1.95%. And then also consistent is the prevalence from the CGA Polaris group. And I already talked about this previously. So if we look at the recent studies, there are a number of studies that have reported different prevalence estimates for hepatitis B. But what you will see is that there isn't really a very robust nationally representative study which can give us a very good estimate in terms of original data. So of note is the Murekar et al. Study recently published and was done in children. But across different studies, you will see there's a whole range of kinds of population that studies have enrolled. So some have enrolled general population, some have enrolled patients because these are hospital-based studies. Some of them enrolled healthcare workers, and some of them enrolled, a lot of them in fact, enrolled pregnant women and blood donors. So a large inconsistency in the kind of population that is included in these studies. What is also variable is the testing method. So while most of them did surface antigen, some of them have used other methods. And so this could possibly account for the discrepancy that you see here in terms of the prevalence estimate reported. So of course there are limitations in the current literature, and the quality of data is highly variable across studies. Most of them have a combination of robust and non-representative studies and have enrolled different age groups at different time points. There's paucity of age-specific and sex-specific data. So if you're wondering if we have a robust estimate of whether males or females are more commonly affected, we don't. Also, we don't have stratified data by age. There's a healthy donor effect in terms of enrolling blood donors in studies, because the ones that come in for donation are more likely to be healthy. So the estimates that arise from those studies may be an underestimate. And of course, as you saw from that table, what we have is mostly subnational data and most of them have targeted, or some of them have targeted high endemicity areas like tribal areas. I did not mention the prevalence of chronic hepatitis C, just quickly mentioning. This is also from a systematic review. So the range that studies reported was a big range, 0.09 to 15%. But you could tell that probably this large range is because of those types of populations that are involved. So if we just take the estimate from community-based studies in blood donors and pregnant women and general population, the estimate is 0.85% prevalence of chronic hepatitis C in India. And this accounts for 6 to 12 million chronic HCV infected people. And of these, 3 to 9 million have active HCV infections. Chronic HCV accounts for 12 to 32% of HCC and up to 20% of cirrhosis. So important cause of both of these liver complications again. So coming on to mortality, what you see from this bar graph is the division of cause of death in HPV and HCV from these two bars. So the darkly shaded portion is the mortality from cirrhosis, and the lightly shaded one is hepatocellular carcinoma, and then the very, very darkly shaded one is acute hepatitis. So you can tell here that large proportion of the deaths that happen in HPV and HCV is due to hepatocellular carcinoma and cirrhosis. And to get an estimate of the absolute numbers, you'll see them here. So these are the estimated deaths in absolute numbers. And the age standardized death rate per 100,000, again 7.8 per 100,000 for liver cirrhosis due to hepatitis B. So this is again very important in terms of the burden, so high burden there for mortality as well. This was a paper that arose from the Global Burden of Disease study. And what they've reported here is the incidence rate for liver complications due to hepatitis B. So they've included both cirrhosis and HCC here for this estimate. And they've compared the percentage change globally versus India. So 2007 to 2017, what is the percentage change for both of these liver complications? So for the global estimate, you'll see at least a point estimate showed a reduction in the percentage change, 2007 to 2017. But for India, there's actually a positive percentage change. But then the confidence interval suggests that this is not a very reliable estimate. Again, there's indication that there may be increase in the death rate due to liver complications. So cirrhosis and hepatocellular carcinoma. For the global estimate, a reduction according to the point estimate, and here an increase with again a confidence interval that's not very reliable. And then this trend holds true for both cirrhosis and liver cancer individually as well. And I will finish by reiterating what the last three speakers talked about, which is the WHO Global Health Sector Strategy on viral hepatitis. It aims for a reduction by 65% by 2030 of deaths from chronic hepatitis B and C, and a reduction of 90% for new cases of chronic hepatitis B and C. Why I talk about this here is because the only way that this can be achieved is through a public health approach. And so we need concerted action from different lines, different professions within the medical discipline. And all of these different measures that you can see here enlisted have to form the backbone of those elimination efforts. And that's the only way that we can achieve those targets. And I'll finish here. Thank you very much for your attention. And I wish you good luck. Thank you.
Thank you so much, Dr. Mania. Dr. Mania is also the nodal officer, and she's playing the instrumental role in spearheading the endeavors and spreading the education and knowledge dissemination for viral hepatitis. And indeed, that lecture was very, very insightful with the burden of hepatitis B and C prevalence in India. Thank you so much. And I now invite Dr. Ayesha to kindly administer the oath.
Good afternoon, everyone. I am Dr. Aisha, and I request you all to switch on your video cameras and your audios as well for the pledge. And I request you all to raise your right hand and kindly repeat after me. I pledge that I will try to keep my liver healthy.
I
I
pledge
pledge that I will try to keep my liver healthy.
I pledge that I will get myself and my family tested and vaccinated.
I pledge that I will get myself
myself
and my family tested and vaccinated.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
Thank you all.
Thank you so much, Dr. Aisha. The forum is now open for question and answers, and I request the panelists who have actively been answering the queries that were posted in the chat box as well. I request the participants to kindly drop in your queries in the question and answer box that is available on the platform.
I think two people have their hand up. I don't know if they have questions.
I request the participants whosoever have their queries can please post it in the question and answer box. Hirom Ranjita Devi and Mona Lisa Mohapatra, we see your hands raised. If you have queries, can you kindly post it in the discussion box? I believe the speakers have touched upon most of the aspects of the subject, and it was very, very explanatory and very well comprehended. So with that thought, I believe the queries can be, we can have the queries at this address. So in case if you have any queries, we do have a question. The question is, what is the dose of immunoglobulin for newborns? And if I may request Dr. Ajit to...
It's 0.5 ml.
I hope that answers your question. Madhavi? Any further questions? I think we can give another minute to our participants. I'm pretty sure about that. So in case if you have any further queries, please do drop into us at webinar.ilbs@gmail.com. Also, we would be really eagerly waiting for your feedback on the webinars and our efforts so that we can improvise. In case if you have any suggestions, we would be really looking forward for your feedback. And please do get in touch with us at the www.theempathycampaign.com. Get connected with us, know more about our endeavors, know more about what is happening with the initiative, and looking forward to having your feedbacks and your suggestions at webinar.ilbs@gmail.com. Please be patient for the next 3 days. You'll be receiving your certificate via your email. Thank you so much for participating and making it successful. So thank you all for joining us for the webinar today, and a special appreciation and thank you for all the support that we received from the principal of Nursing College, Dr. Mini George. We couldn't have done without your help and support, ma'am. And to all the nursing students who joined with us today, we really appreciate your participation, and I'm most certain that you must have gained a lot of insights and knowledge as far as the viral hepatitis prevention and control is concerned. Thank you so much. Dr. Mini George, would you like to share a word or two with the students and regarding the endeavor for today's webinar? You're most welcome to the platform, ma'am.
Thank you, team, for having given us, taken time out and brought on platform very eminent people who took classes on very important topics. And I'm happy that many of the students did take part, and they were attentive and available throughout the sessions. So I take this opportunity to thank Dr. Umesh Kapil and all of you there on the team who has given us this time, and thank you one and all.
Thank you so much, ma'am, for your kind appreciation. And we do look forward for your support in our continued endeavor, the dissemination of knowledge regarding viral hepatitis from the Empathy Campaign. May I now request Dr. Umesh Kapil, would you like to please close in the webinar with a vote of thanks, sir? Closing remarks, sir. So could you please unmute your microphone?
Apologies. Namaskar, Mini George ma'am, and all the faculty members of College of Nursing. We are personally grateful to you for organizing this webinar, and we look forward to your continued support. And we are sure that the students must have gained little extra knowledge, some new knowledge after attending this webinar. And once again, thanks a lot. Most grateful to you. Namaskar, ma'am. Can we close this webinar, ma'am? Mini George, ma'am?
Yeah, yes, sir. Thank you.
Thank you very much.